Hello and welcome to another Facebook Live with MedStar Health. My name is Michelle Carter and I'm excited to be here with you today for National Wear Red Day and during American Heart Month, an especially important time to talk about women's heart health. Heart disease is the leading cause of death for women in the US, and what makes it even more challenging is that symptoms in women don't always look the same as they do in men. That's why awareness, early recognition, and detection, prevention are so critical, and why conversations like this can truly save lives. We have an incredible team of female specialists here from MedStar Heart and Vascular Institute, including cardiac surgeons, vascular surgeons, interventional cardiologists, electrophysiologists, and heart failure specialists. Today, we have four of our experts. We have cardiologist Dr. Kerunne Ketlogetswe, heart failure specialist Dr. Richa Gupta, interventional cardiologist Dr. Rimmy Farrakhan, and Kerry Lynch, a physician assistant in electrophysiology. They're here to share their expertise, answer your questions, and help break down what every woman should know about heart disease. So keep watching, share this broadcast with your friends, and if you have any questions, please share those in the comments below. We'll take some time to answer those as well. All right, so thank you all for joining us. We really appreciate you taking the time to speak with our audience today. It's a very important topic, one that I'm personally invested in, as many of you guys are out there as well. So let's get started with our questions. I'll start with Dr. Ketlogetswe. Could you share what is a cardiologist?
Thanks, Michelle. Good afternoon, everybody. I'm Dr. Ketlogetswe. I'm a non-invasive cardiologist, and I practice out of MedStar Harbor Hospital up in Baltimore. A cardiologist is a heart specialist, and so we specialize in diseases of the circulatory system. So we take care of things from simple things like managing hypertension to managing heart failure to managing rhythm abnormalities, as well as valvular disease. We take care of patients from diagnosis and through management phases.
Thank you. And what specific conditions do you typically treat as a cardiologist?
Part of the reason I love my job is I get to see a lot of different things. I'm a preventive cardiologist, which means I like to see people before they actually develop overt heart disease and prevent them from having their heart attacks, prevent them from getting diseases which will increase their risk for having heart failure, for example. I treat things as simple as blood pressure to cholesterol abnormalities. We treat people who have already had an event, such as having had a heart attack or had heart surgery in the past, and we manage them all throughout their lifespan from the beginning of their disease through even advanced stage diseases. Sometimes you'll meet some of my other colleagues who take care of people who have more advanced forms of disease, which require even more specialist management.
Okay. Thanks for explaining that. Let's dive a little bit more into heart disease. What are the typical symptoms for heart disease in women, and when should they be considered urgent or an emergency, and what are those warning signs that we should be looking out for?
Sure. So both men and women can have what we consider typical heart symptoms if they're having a heart attack. By that we mean that they can describe chest pressure, heaviness or discomfort. They can experience shortness of breath, feeling like their heart's racing or skipping beats. But sometimes women have more subtle symptoms or symptoms that can often be overlooked or not associated with heart disease. For example, women may complain of a fatigue or feeling more tired than they normally do, unable to complete their normal, usual tasks. So while they may not describe the elephant sitting on the chest, they may say they have what they think is indigestion, right? Or dyspepsia, feeling like something's not right in the middle of their chest. So my recommendation or tip to all patients is that if you have new symptoms, something that is different and out of the ordinary for you, you should listen to those symptoms and bring them to attention of your doctor.
Very important reminder to pay attention to your body. And women, we bear the brunt of, family life and all of that. So it's important that we pay attention and, stop and recognize those symptoms. Um, could you share a little bit more about the risk factors as
Mm.
well for heart disease?
Absolutely. So when we see our patients, we tell people to know their numbers. There are certain traditional risk factors for heart disease, the most common ones being high blood pressure, having elevated cholesterol, if you have elevated blood sugar or diabetes, if you smoke, right? Obesity can also be a risk factor. There are some things that you cannot change. For example, having a family history of someone in your family having had heart disease in the past can increase your risk. There are certain genetic cholesterol abnormalities which can be out of your control, which you cannot change. But we tell people that there are things that you should know, you should have them checked and evaluated. And if they are abnormal, that is the reason to go and see your doctor or cardiology to really aggressively work on those risk factors.
Thank you very much. And what questions should a first-time cardiology patient ask their doctor if they have symptoms?
I always tell patients, no matter how small or how large, bring those symptoms to your physician's attention. So anything that is out of the ordinary or new for you, we want to hear about it, right? So if you are experiencing shortness of breath, if you are having symptoms of palpitations or unusual breathing patterns, um, pain in the legs, weakness, swelling in the legs, those are sort of symptoms that we want to hear about. As well as making sure that, again, like I said, knowing those numbers when you come in, my blood pressure has been noted to be elevated, my cholesterol is this, these are my blood sugar numbers. We really want to empower people to know their numbers and act on those numbers.
And related to that point about cholesterol, why are your cholesterol numbers so important? And what's the difference between good and bad cholesterol?
Great question. So cholesterol is a substance that we get both from food and that is produced by our liver. It is needed for certain functions in our body, and there are certain normal levels. If you have too much or high levels of the bad cholesterol, it it accumulates inside your blood vessels and can cause them to narrow and or cause an acute heart attack. So when we talk about the bad cholesterol, we're typically talking about something called LDL cholesterol. And that's a number that we want to know and keep as low as possible. It is directly related to heart attacks, right? The higher that level is, the higher your risk for having a heart attack. That's the number that we really focus on and work to get low. The good cholesterol can be protective in certain circumstances, but the one that we really want to know and care about is that bad or LDL cholesterol level.
And along with cholesterol, we want to talk about blood pressure as well and knowing those numbers as well. What's considered good blood pressure, and what does the top number mean versus the bottom number? I always get confused with this part.
Yeah. So sure. So blood pressure essentially just measures the pressure of your blood flowing through your arteries. That top number is called the systolic blood pressure, and it measures what the pressure is when your heart actually contracts or squeezes. The bottom number is the diastolic blood pressure, and that measures the pressure when your heart is in between beats or relaxing. A normal blood pressure should be less than 120/80. That's what we consider normal. Once that top number is above 120, then we start to say your blood pressure is elevated. If it's above 130, then we consider you to have hypertension or high blood pressure. And in that range, we really want people to be doing things to lower their blood pressure through diet, exercise, and lifestyle changes, right? Once it's above 140 is where we start to intervene and give people medications to bring that blood pressure down. Because as I mentioned earlier, having a high blood pressure is one of the biggest risk factors for heart disease later in life. So the sooner we can get on top of your blood pressure and keep it low, it reduces your risk for having a heart attack or heart failure as well.
All right. Thanks for explaining that. I understand it a little bit better now.
Yeah.
Um, let's talk about diagnosis. What tests do you use to diagnose a heart condition?
Okay. We have a lot of tests up our sleeve as cardiologists. So when you first visit a cardiologist, probably the first test that everybody will be a physical exam where we listen to your heart and see if there are any abnormalities. In our office, we can do something called an EKG, which looks at the heart rhythm to see if there are any abnormalities there. The next test that we can do is something called an echocardiogram or an ultrasound of the heart. That ultrasound checks to see how thick the muscles of the heart wall are, how well your heart squeezes, if there are any valve abnormalities that need to be addressed. Then we can do things that are also imaging, right? We can take pictures of the arteries of the heart to see if there's evidence of plaque there or if there's actual narrowings. These are sort of all of our non-invasive tests. We can do stress testing. If you're having symptoms that are concerning and sound like maybe related to the heart, we either put people on a treadmill to exercise them and see if we can recreate those symptoms, or if they're unable to exercise, we can give them a chemical type of test to see if there's any abnormalities, in addition to taking pictures to see if there's abnormalities in the way that blood flows to the heart. If those tests are abnormal, I might send you to one of my other friends here, right, who will take a look and see with more invasive or more advanced testing that may involve taking a visit to the cath lab, for example. Dr. Farrakhan is going to tell you a little bit about that, so I'll leave that to her. I might send you to see our rhythm specialist. Kerry Lynch will tell you some of her tests, right? And Dr. Gupta also does other testing to look at heart abnormalities. So we have a lot of tests, but the most basic ones when you first see a cardiologist usually involve looking at the rhythm of the heart, the function and the structure of the heart, and taking it from there.
I like that team approach too, like looping everyone in. If we need to take things a step further for treatment, we have someone ready and able to help with that. So thank you for explaining that, Dr. Ketlogetswe. One more question before we turn over to our other specialists here. What treatments do cardiologists provide? I imagine it's a plethora of things, but what treatments do you provide?
Um, Again, this is the fun part of cardiology, is that we have a lot of really effective treatments to help people manage heart disease. Things as simple as blood pressure medications, cholesterol medications, blood thinners, for example. We have medications that help lower blood sugar, which improves heart function as well. Those are just sort of the medications that we can give to people. One of the biggest prescriptions that all of us give, though, involves lifestyle, right? Really getting people to lead an active lifestyle. So that's always the cornerstone of our management, helping people eat healthier, exercise better, have a better weight, right? Get into a healthier weight class, in addition to some of the medications we use. In my lifetime sort of practicing in cardiology, I've seen amazing medications come along to manage things. For example, cholesterol. We have more and more and more medications that come along that have even better benefit for people. You can take a pill to manage your cholesterol, you can take an injection that you do twice a month, and there are even now medications that are only twice a year. So just seeing the whole spectrum of medications is really great. We have a really big arsenal of things that we can do to manage heart disease.
That's amazing. That's amazing and reassuring to hear, how things have advanced as well to address patients' specific conditions. So thank you very much. At this time, I want to pause and welcome our viewers again. Thank you all for tuning in to this very important conversation about women's heart health. Today is National Wear Red Day, so I hope you're wearing your red in celebration of American Heart Month, learning all about how to take care of your heart, knowing your numbers, getting and staying healthy. I'm joined by four of our female heart health experts here. I have cardiologist Dr. Kerunne Ketlogetswe, heart failure specialist Dr. Richa Gupta, interventional cardiologist Dr. Rimmy Farrakhan, and Kerry Lynch, a physician assistant in electrophysiology. We have much more to discuss. We just talked about the importance of a cardiologist, what conditions they treat, and what treatments are available, but we have more to share. So keep watching, share this with your friends, and share us your questions in the comments below. At this time, I do have a viewer question. So I want to take some time for that. This one comes from Charmaine Lescott. Thank you very much for submitting this. Charmaine is asking, if you have a history of GERD, how can you tell the difference between a GERD flare-up and heart or blood pressure? High, I guess, elevated blood pressure.
That's a great question, Charmaine. And that's why we're sort of stressing the importance of bringing your symptoms to your doctor so we can decide on tests that will help us differentiate between things that are coming from the GI system and things that could potentially be coming from the heart. And that's why we use some of the tests that I told you about, for example, EKGs to help us, echocardiograms, and stress testing if we think that that's indicated, right? Hearing the story is a big piece of it, right? How you describe your symptoms makes us help decide which one we think it is, as well as your own risk factors, right? So if you have many risk factors for heart disease, it makes it more likely that it may be coming from the heart. And that's when we will do a lot of our diagnostic testing.
Okay, perfect. Thank you very much, Dr. Ketlogetswe. I have another question from Aisha Blow, who's asking, what warrants one to need a visit from a cardiologist besides obvious heart failure or heart attack? Can you get an appointment as a preventive measure?
Absolutely. There's a really big push. Again, part of the reason we educate our patients during Heart Month and through experiences like this is to tell people that the importance of prevention. And so if you have risk factors for heart disease, we want to be acting on them and we want to be acting on it early. My favorite patients are patients who come and see me in their 30s and 40s for evaluation, for testing to see their own individual profile and what we can do to optimize their risk factors, right? And have them leading a more heart healthy lifestyle, right? So if you have concerns, definitely bring them up to your primary care provider. And if it's appropriate, they will send you to come and see us. I'm sure after this session, you will give people information on how to get appointments with MedStar if you're concerned and want an evaluation.
Yes, absolutely. And be sure to keep an eye out for that information in the comments below. I have one more question before I go to some of my own. This one comes from Mary Marbley, and I think this goes back to your point, Dr. Ketlogetswe, about knowing your numbers. Mary is asking if your calcium score is high, is a statin the only way to get your score low?
Thanks for that question, Mary. That's a good question. So what Mary is referring to is one of the tests we do is to look if there's calcium inside the arteries of the heart through a simple CT scan that doesn't involve any dye. And if you have evidence of calcium in your arteries, it implies or tells us that you have plaque that has already formed in your arteries. When we see that plaque, we want to be really aggressive to prevent the plaque from getting any worse or getting increasing. Statins are one of our strongest tools in our toolbox to help people lower their cholesterol. Some people cannot tolerate statin medication, and we have many other cholesterol lowering medicines to get those cholesterol numbers lower. So sometimes that may involve a pill, it may involve taking a shot, for example, but there are other tools we have in our toolbox. But statin is usually the very first one that we try. Many things you can do with lifestyle and diet to bring your cholesterol levels down, but most people can't get their levels low as we need them to be in order to help limit the progression or furthering of the calcification or plaque deposition in the arteries just through diet alone.
Okay. Thank you for explaining that. And thank you, Mary, and all of the rest of you for sharing your questions with us. We'll get to more throughout the live stream. Right now, I want to turn to Dr. Richa Gupta to talk about heart failure. So could you share what is a heart failure specialist?
Yeah, thanks, Dr. Michon, and thank you for having me for this. I'm honored to be here to talk to everybody about heart failure and women especially. So a heart failure specialist, which is what I am, sometimes officially called an advanced heart failure or transplant cardiologist. It's a lot of words. We're kind of like a super specialist in the cardiology world. A heart failure specialist specifically is dedicated to managing patients with a weakened or stiff heart muscle using a large armamentarium of medications and cutting edge devices on top of those medications. So what we do kind of day to day is first diagnostic testing to understand the exact reason for having a weak or stiff heart muscle, things like genetic testing or a cardiac MRI, for instance. And then at the same time, we spend our time really fine tuning and adding medications that are life saving, that improve quality of life, and can actually improve heart function and keep patients out of the hospital. We importantly also spend time monitoring subtle changes in our patients, looking for any worsening that might suggest that a patient needs more advanced interventions like special devices that can improve symptoms or monitor fluid or address valve issues if the medications aren't working 100%. And then lastly, and then I would maybe most importantly, we make sure that if patients aren't responding to all these therapies, that we're not missing the window where we can successfully offer certain surgeries that I call heart replacement therapies. So things like left ventricular assist device or heart transplant. These are things that we use when the heart failure is end stage and just isn't responding to medical and device therapy anymore. So we don't just kind of watch our patients' hearts. We actively kind of manage the map of care and monitor carefully for disease progression so we can jump on a treatment plan proactively.
That's great to hear. Great to hear about that proactive approach. Dr. Gupta, could you share a little bit more about what heart failure is and the other conditions that you typically treat?
Yeah, so heart failure is a scary name. In the medical world, failure, it doesn't mean that the heart has stopped. It basically just means that the heart is not able to keep up with its workload, either because the pumping muscle, like I said, is too weak or stiff. The heart as a pump has to deliver a certain amount of blood or water, to the rest of the body. And heart failure is kind of what happens when that pump cannot push that water out effectively or manage it effectively. And what I would say is there's kind of two broad types that we typically treat based on the ejection fraction. The ejection fraction is how much blood your heart pumps out with each beat. So the first type is heart failure with reduced ejection fraction, and that occurs when the muscle becomes thin and weak. And this can be due to different reasons, which we investigate: coronary artery disease, or genetic causes, or inflammatory conditions like sarcoidosis. And then a second type of heart failure is heart failure with preserved ejection fraction, where the heart muscle might be strong, but the walls might be thick or stiff. And so they can't relax enough to fill up with blood between beats, which causes patients to retain extra water. And this type of heart failure is actually more prevalent in women than it is in men. And these are kind of the broad categories of heart failure that we treat as heart failure specialists.
And when would a woman or when should a woman see a heart failure specialist?
That's a great question. And I think a really important message here is that you don't need to wait until you feel worse to see a specialist. A lot of women and men, but I say this to women especially, who tend to be busy with other things like caregiving and family life and that kind of thing. Many see one shortly after a heart failure diagnosis just to get a second opinion on, what their roadmap should be and understand the trajectory of their disease. There's nothing wrong with seeking an early opinion from a specialist, and women especially should feel empowered to do so. So some of the things that you might be experiencing that may trigger asking for a referral might be symptoms. So having shortness of breath, fatigue that aren't improving on current medications. If you've been hospitalized for excess fluid for your heart failure more than once, if you find that it's been difficult to tolerate the standard medications that we use to improve heart failure, like if they make your blood pressure too low or just make you feel bad. And if your ejection fraction is still low despite all of these treatments. So seeing a specialist, also a really important point, doesn't mean that you're not going to continue seeing your current doctors or your current cardiologist. As a heart failure specialist, we work with your primary care, with your general cardiologist, to just provide an extra layer of expert oversight.
Very good to know. Thanks, Dr. Gupta. Going back to your point about symptoms, what are the typical symptoms for heart failure, and are they different in men versus in women?
Yeah, that's a great question. So most people with heart failure will experience some version of shortness of breath, especially during activity or lying flat at night. They might experience what we call edema, which is lower extremity swelling in the feet or in the legs or the ankles. Sometimes that can also happen in the abdomen. Fatigue is another one. You're just feeling unusually tired or weak, even just sort of doing usual tasks like grocery shopping or chores around the house. And then sudden weight gain because of fluid. So those are sort of some of the symptoms of heart failure. Symptoms can definitely be different in men versus women. Women tend to have, more, what I think, more exercise intolerance and sleep disturbance, and also a lot more GI symptoms. So nausea, loss of appetite, or feeling full after just eating, a few bites of food. They can also have shortness of breath that might happen during chores, and may more frequently than men have more symptoms even at rest or while sleeping compared to men. So on top of that, women are more likely to experience things like depression, anxiety, which sometimes can lead medical providers to mislabel the heart failure symptoms as just like stress or even just cardiac symptoms in general. All of that sounds really depressing, but I think it's important to highlight one positive for women, which is that they respond just as well, if not better, to a lot of the therapies that we have compared to men. There are some device therapies like cardiac resynchronization therapy, where this is a procedure that the electrophysiologists actually do to sync up the heart to improve the forward squeeze with a special pacemaker. And women actually respond a lot better to that treatment compared to men. So while the symptoms might be different and might sound a lot more, there's a whole lot that we can do in terms of treatment to make women feel better.
That's really reassuring. Good to know. All good
Yeah.
information to share about that. Could you share a little bit more about the treatments? What treatments does a heart failure specialist provide? And along with that, what other physicians do you work with? I think you did share a little bit about the collaborative approach, but
Mhm.
could you share more about your treatment approach?
Yeah. Let me, so I'll kind of run through what our special toolkit is, that goes kind of just beyond regular heart care. And the goal, isn't just to keep patients out of the hospital, it's also to extend survival, to improve quality of life, to improve the heart function. The hierarchy of treatments is kind of into three, I would call it three buckets of categories. So the first is medications. So in the last few years, we have revolutionary treatment with a combination of four medications that us and all cardiologists are really expert at titrating or carefully increasing these to the highest dose that your body can handle in order to achieve maximum heart recovery. With that also includes fluid management, so fine-tuning medications called diuretics that help get rid of extra fluid and make patients feel better. So that's medications. The second bucket is device therapy. So that includes the therapy that I just mentioned, cardiac resynchronization therapy, the special pacemaker that kind of makes the left and right sides of the heartbeat in perfect sync. There are also some, minimally invasive procedures that we evaluate patients for, and then I might send patients to one of my partners to, like Dr. Farrakhan, who you'll hear from soon, to implant. So something like MitraClip, which is a minimally invasive procedure to fix a leaky valve without needing open heart surgery. We also have devices like a device called CardioMEMS, which monitors how much fluid a patient has at any given time to prevent buildup of extra fluid and prevent heart failure hospitalization. And then we have devices that help improve heart failure symptoms. You may have seen commercials for some of these devices. They're things like Barostim and cardiac contractility modulation. These are special heart failure devices that are not put in with surgery. They're really just sort of minor procedures that help improve heart failure symptoms by different mechanisms. So we use them when patients are still symptomatic despite being on medical therapy. And then the third bucket, I said there were three, is finally, the things that we use when we ultimately, if we find that the heart failure has progressed to its advanced stages. So those surgeries include left ventricular assist device. That's a durable heart pump that offers good quality of life outside of the hospital and extended survival, and heart transplantation. As far as other physicians we work with, so a lot of partnership that goes into heart failure treatment overall and a large team of doctors. First is sort of other heart collaborators. So primary cardiologists, electrophysiologists, interventional cardiologists, and then cardiac surgeons. They're the ones that do those advanced surgical therapies like left ventricular assist device and transplant. We also work with all sorts of other specialists, though. So we have organ system providers, the big ones, people who have heart failure or cardiology issues in general. may also have kind of endocrine issues, diabetes and thyroid management that can greatly affect the heart. There's a big interplay between heart disease and endocrine disease. So we work closely with endocrinologists to make sure that those are well controlled. Nephrologists too. The heart and kidneys are very connected. If the heart's not pumping effectively, then the kidneys can struggle and vice versa. And so we partner with them, and then sometimes even pulmonologists. And then, of course, there are kind of longer term care partners like primary care or geriatricians for older patients to help kind of manage things like frailty, memory. All of this affects your heart failure, your cardiology care in general, and even palliative care specialists. So these specialists are important. They're often misunderstood as end of life care, but they actually are really, really focused and really good at symptom management, things like fatigue, pain, anxiety at any stage of heart failure, and really help improve quality of life.
Very, very important. We want to make sure we're improving our quality of life. Thank you very much, Dr. Gupta, for explaining that. I do want to take a little bit more time and answer just a couple more of our audience questions right now. Thank you very much, you all, for tuning in and sharing your questions, sharing your stories with us. I have a question from Karen Kramer. And I address this to all of you. Feel free to jump in and answer this. Karen is asking, what is the impact on women's estrogen levels from statins?
I'll take that one. I think I probably think about it in the opposite way, right? About the
Okay.
changes that happen in midlife as women are going through perimenopause and menopause, and that those changes are what can affect people's cholesterol levels. So those levels can actually worsen during the perimenopause and menopause phase. And that's why at times you may need extra medications or medications to help bring your cholesterol levels down. As more and more women are interested in sort of estrogen therapy to manage their symptoms for perimenopause and menopause, we do keep a close eye on those cholesterol levels because you may need some extra medications to help control your cholesterol levels while you're on those medications.
Okay. Thank you very much, Dr. Ketlogetswe. And thank you, Karen, for sharing that question with us. We have one more from OK, who's asking, with diet and lifestyle modifications, can someone stop taking their pressure medication, their blood pressure medication?
We have seen, especially in the era of a lot of weight loss medications, for example, that people are using now. Those include the injectable medications that you may have heard of, like Mounjaro, Wegovy, Ozempic, as well as with bariatric surgery. A lot of people, when they lose the weight, a lot of the metabolic problems that come with having excess weight, including elevated blood pressure, elevated cholesterol levels, elevated glucose levels, those do get better with significant weight loss, right? And so I've had people who have been able to either reduce their medications or come off of it completely if they lose enough or significant amount of weight that they can come off. And so this is why we always advocate for the lifestyle modification. It's the underpinning and it's the foundation of management of heart disease because it can really help minimize or reduce the amount of medications that you need to manage your health conditions. So yes, with lifestyle, people are able to. Now, that doesn't mean that you still may not require your medications, maybe at a lower dose, in order to help manage your risk factors. And certainly, even if you've had a heart attack, if you have certain conditions, these medications are still recommended, right? Even if your levels improve, because the medications help prevent further progression of heart disease. So if you've had a heart attack, for example, a cholesterol lowering medication is indicated to keep those cholesterol levels as low as possible.
Okay. Thank you very much, Dr. Ketlogetswe. I have one question for Dr. Gupta before we move on to our other specialists. This is related to something you mentioned a little bit earlier about the ejection fraction as a measurement for evaluating heart health. Could you share a little bit more about that ejection fraction and how you use it? This is related to one of our audience questions
Yeah, that's a really good question. So an ejection fraction is the amount of blood that the heart pumps out kind of with every beat. A normal ejection fraction is 55 to 60% roughly. And we kind of dichotomize this as cardiologists when we're looking at a patient, only because it helps us determine what therapies are best to sort of improve the heart function. So if the ejection fraction is reduced, then there are four medications that we know work really, really well to help strengthen the heart function and get the heart function back to normal, even what we call is, heart failure remission. And these medications work by kind of blocking the stress hormones between, the brain and the heart, in order to improve the heart function. If the heart function is preserved or the ejection fraction is normal, meaning, 50% or higher, but there's still heart failure symptoms, then we're looking at kind of other causes that might be contributing to the heart stiffness or the heart dysfunction. And the treatment algorithm is a little bit different. We're focused on using medications to help eliminate fluid and decongest. We're looking at the valves, we're looking at rhythm, we're looking at things like high blood pressure, which can cause heart muscle stiffness too, just like it does with stiff arteries. And working on really kind of treating all of those things, including, weight loss and weight management, because those tend to occur more frequently with that type of heart failure. So, the strategies are just a little bit different based on what the ejection fraction is in terms of getting patients better.
Perfect. Thank you very much for answering that, Dr. Gupta. Now I want to turn to one of our other specialists, interventional cardiologist, Dr. Rimmy Farrakhan. And let's talk about a little bit more of what you do. Can you share what is an interventional cardiologist and what other physicians do you work with?
Hi, I'm Dr. Rimmy. I work with MedStar Heart and Vascular Institute. I'm very excited to be here, very honored to be able to speak on this topic. I think Dr. Ketlogetswe and Dr. Gupta have done a great job talking about different aspects to cardiology. It's such a broad system with so many different sublevels to it. And especially Dr. Ketlogetswe, sorry, who mentioned all the variety of testing that can be done to assess various cardiovascular dysfunctions. As she mentioned, those tests are non-invasive. Now, if there was anything abnormal in that test that has been done, then they can be referred to an interventional cardiologist if they need a invasive mechanism to figure out why those tests were abnormal. So we address the issues with the heart, the structures inside the heart, the blood vessels that go to and from the heart in a minimally invasive manner, using very, very skinny little wires and tubes to be able to do our procedures, avoiding the need for cardiac surgery, at least up till that time. And in terms of like which physicians we work with, like Dr. Gupta and Dr. Ketlogetswe mentioned, it's a pretty multidisciplinary field, even within cardiology. With interventional cardiology, I often work with heart failure doctors to help figure out why a patient has heart failure. With non-invasive cardiologists, if patients go to them for chest pain and we're trying to figure out the etiology of that chest pain, we're in close connection with them. I work with electrophysiologists. Like oftentimes patients have abnormal heart rhythms. Like, why is that? Is that a more heart failure related problem? Is it a more ischemic, a blockage in your heart artery problem? We're working with cardiac surgeons because there are certain things that we may find in our invasive testing that might warrant something that's even more involved and might need surgery, like a bypass surgery or a surgical valve placement, for example. So we're in close relation to them. We also, let's see it. Those are like, lots of different providers that play a role in us managing their heart disease. And also, of course, we have patients that come in through the emergency room if it's an acute event. So we are right there to take care of that problem emergently if needed.
That's very good to know, and a good
Mhm.
segue to my next couple of questions. So, could you share what conditions do you typically treat, and then where do most of your patients typically come from? You
Mhm.
mentioned, sometimes the ER, cardiology,
Yeah.
primary care, even. So, could you
Mhm.
explain a
I
little bit
can
about that?
I can try to go through this like system based a little bit, I guess, in
Sure,
a
yeah.
way. Um, so, one big thing that people think about women, especially we think about heart attacks, right? Clutching your chest pain, in a lot of pain, you come through the ER. For those patients, we do an emergent cardiac catheterization to look at your heart arteries. If there is a blockage there, and that's what we worry about with a heart attack, is 100% blockage of your heart artery, then we can go in, use a tiny little balloon to open up that blockage, and put a stent in to keep that artery open. So that's one thing we do in angioplasty or a stent placement. We have patients that come in with heart failure. So not only can we inject the arteries with dye and take a look at our heart arteries, but we can also measure the pressures inside their heart and lungs to see how they are from a volume standpoint, from a fluid standpoint. Do they need further medications to help optimize those pressures inside their heart and lungs? And it also gives us a sense of how their heart is squeezing. Like, I know Dr. Gupta did a really great job explaining what an ejection fraction is, but someone can have a low ejection fraction, but they can be so well managed by their cardiologist with the medications that they are still able to get perfusion to the rest of their organs. And there are some people who may not be as well compensated. They may need extra help beyond just medications, as was mentioned with, assist devices, whether they need other circulatory support systems, pumps. So these cardiac catheterization numbers give us that information. Then we have patients who may have a valve issue, like a very, very tight valve or very, very leaky valve. If they are not a surgical candidate, we have minimally invasive ways of addressing those issues. We can replace our aortic valve. We have clips for people who have leaky mitral valves, as was mentioned earlier. And a lot of these procedures, they don't involve you being cut up to replace that valve. So if you're not a good surgical candidate, we can do this. And, a lot of the times back in the day, the older you got, the less options you would have in terms of what would be offered to you. But now we have a lot more minimally invasive options for you. Mhm.
Very good to know. That also leads to my next question about the typical procedures that you offer. Could you explain a little bit more about anything that's minimally invasive, local
Mhm.
anesthesia, twilight, and
Yeah.
radial versus femoral?
Yes.
Yeah.
So like I said, these are minimally invasive procedures. What that means is we're not cutting up in your chest. There's no sternotomy, no wires, like no drills or anything. The best example that I give to my patients is like, when you get an IV placed or you're getting a blood draw, they put a little tube in. So just imagine that tube slightly bigger. I'm literally putting that tube in to either your artery or your vein to be able to do this procedure. Regardless of what procedure it is, whether it is a heart failure related procedure, a valve related procedure, a coronary artery related procedure, they all involve like very, very skinny little tubes um, to go up and get the information that we need and to be able to do these procedures. Of course, the tube sizes can be slightly bigger when you're dealing with slightly bigger equipment like valves. And ideally for valves, we do like to use our femoral artery rather than our radial artery because the valve is, as of right now, the way our technology is, too big to be able to use our radial artery. Oftentimes, otherwise, when people come in with a heart attack and we're just looking at the heart arteries or replacing a stent, then most of the time we are able to go through your wrist. And that is really preferable and beneficial in a lot of cases because it's a smaller artery, you have lower complications, lower mortality, and patients don't have to be on bed rest, right? Like, yes, we watch your wrist, but patients are still able to move around, they can sit up, and that adds to patient satisfaction. When you are going femorally, it is a bigger artery, you worry about bleeding, you want to make sure that once we have
finished our procedure and we have secured that artery so that it's not bleeding, that the patient not move around as much. Now, because these are minimally invasive procedures, we don't usually use general anesthesia. We're able to give them what we call conscious sedation, or like I tell my patients, it's like you're in the twilight zone, like you're kind of in and out of it. And I've had like a variety of reactions. Like some patients just fall asleep. They're like, I don't want to see, I'm going to fall asleep. Don't fight it. And they're fine. Some are like conscious enough and they like to watch what we're doing, and that's fine with us too. But essentially, we don't knock you out. Oftentimes, we may ask you to do certain things like take a deep breath for us or cough for us, because when we're working with these catheters, any sort of movement you do, any sort of breathing that you do can kind of change like the physiology or the hemodynamics inside your body and move our catheters a certain way. So that's why, if we can, we like to do this with the patient, a little conscious for that. But it is like minimally, like I have rarely had patients complain about pain or remembering like the pain of it after the fact. And because we evolved so much in terms of like the technology we have, there's so many things that we can treat. Like I talked about valves, we talked about putting in patients who come in like an acute heart failure exacerbation, we have certain pumps that we can place before they are put on something that's a little bit more semi-permanent or permanent, such as balloon pumps or Impella devices, which are like temporary assist devices while the patient is being worked up for heart failure. Dr. Ketlogetswe probably gets a lot of high blood pressure patients. We have, patients who may have had high blood pressure for years on end, and they're on all these medications, and we can't figure out what's going on, or we've at least ruled out that it's not because of a certain list of conditions. Well, we now have a procedure called renal denervation therapy, where we can kind of burn these little nerve bundles that are near our kidneys that can contribute to your high blood pressure. And that's a minimally invasive procedure. And to the viewer that had the question about, can I come off my blood pressure medications? Well, that's a procedure, and people who fit the criteria for that procedure, they have been able to come off meds down the line. We do a lot of procedures to help monitor, pressures inside the heart. Dr. Gupta mentioned cardiomems. Again, we can go up the leg, put a little tiny monitoring device, like literally smaller than a AAA battery, that kind of sits in your pulmonary artery to check what those pressures are. And we can give that data like to our heart failure physicians, like they're monitoring those constantly to tailor a patient's medications. I had mentioned we work with electrophysiology doctors. Kerry's going to speak a little bit more about that. Sometimes we can also help them put temporary pacemakers while they are waiting to get a more permanent fix as well. So I feel like there's a lot going on with interventional cardiology. There's a lot of subspecialties within interventional cardiologies, and it's just going to keep growing with all the technology that's coming around and evolving.
Very good information, very good news on the horizon of, the treatments that are available to us and how much things have advanced for heart treatment. So thank you very much, Dr. Farrakhan, for explaining that. Now, last but not least, I want to address our next specialist, Kerry Lynch. She's one of our physician assistants in electrophysiology. Thanks again for joining. Could you explain what is an electrophysiologist and who should see you?
Yeah, absolutely. So like you said, I'm Kerry. I'm a PA. I work in the outpatient setting with our different team of electrophysiologists. And so, what is an electrophysiologist? We focus on the heart rhythm. So we're looking at the electrical system of the heart, which will include kind of a variety of different conditions, which I think we'll probably get to talking about here soon.
Awesome. Yes. Could you share a little bit more about the typical conditions that you treat, for example, AFib, and the difference between seeing a cardiologist versus an electrophysiologist?
Yeah, so, when we think about what kind of conditions we're treating in electrophysiology, we classify them as mostly arrhythmias, so something that's outside of the normal rhythm of the heart. That can be kind of a variety of things. Some of them can be too slow of heart rhythms, some of them can be too fast of heart rhythms, and others are just irregular. They're just not the normal heart rhythm. One of those irregular heart rhythms is atrial fibrillation, like you mentioned. And so, those are things that can be managed, at least, when they're being found and starting off by a general cardiologist. Absolutely. They're able to, help with starting medications to, reduce the risk of stroke and helping to manage the symptoms that come with the arrhythmia. But, sometimes if they're either not responding to those initial treatments, or if they want to talk about other treatment options that are a bit more invasive, then they can be, sent to see us in electrophysiology.
Okay. And talking about treatments now, what treatments do you provide? I know we mentioned like pacemakers, defibrillators, anything else for monitoring the heart.
Yeah, absolutely. So, like I mentioned before, some of the heart rhythms that we treat are for rhythms that go too slowly. And so, for patients who have symptoms from too slow of a heart rate, then we can go ahead and we can put in pacemakers. Some can be, temporary, like Dr. Farrakhan had mentioned. Others can be more permanent devices that will stay in the body for, years and years. Other things that we can do is we can put in defibrillator devices. Those are devices that are for patients who are at a higher risk for dangerous heart rhythms coming from the bottom chambers of the heart. Those can be, sometimes patients with heart failure, similar to what Dr. Gupta had mentioned earlier, or patients who have had a history of those rhythms. So we can put in, those devices that help to protect against those dangerous rhythms. And then in terms of, other treatments that we do, similar to what the other providers have said, we also help with, medication management, especially, atrial fibrillation is a big population of patients that we see. So we can help to manage the symptoms, the heart rate, the heart rhythm itself, and then stroke risk reduction, all through medical management, or offering, procedures such as an ablation procedure that helps to control the rhythm as well.
That's very good to hear, and a good segue to one of our audience questions. I want to go back to Karen Kramer again, who's asking, is an atrial flutter, is it not? It's a far too distant cousin of AFib. Are atrial flutters and AFib somehow related?
Yeah, so they're both arrhythmias that come from the top chambers of the heart, so the atria of the heart. They are similar but slightly different. Atrial fibrillation is a very irregular rhythm, and so that can cause your heart rate to kind of jump all over the place. Atrial flutter is a little bit more of a regular rhythm. We typically think of it as kind of this short circuit that you have in the top chambers of your heart. But similar to atrial fibrillation, those can be treated with medications and ablation procedures as well.
Okay, very good to know. And thanks again, Karen, for sharing your question with us. Um, Kerry, I want to wrap up a little bit with some of the smart devices that are available for detecting heart arrhythmias. Sorry to mispronounce that. And if a device detects a heart arrhythmia, what should someone do? What's that next step the patient should take?
Yeah, so sometimes patients will, be monitoring their blood pressures at home, and sometimes blood pressure cuffs can tell you if you're having an irregular heart rhythm or not. Other times, patients have, smartwatches or different devices that are wearable on your wrist, and those will give a notification saying that it's noticing an irregular rhythm. Those are good at picking up what is outside of the normal, but it's hard to differentiate what that rhythm is just based off of those devices. So if you are getting those rhythm notifications, I would recommend, following up with either, your primary care, your general cardiologist, or coming to see us in EP, and we can, do other different types of monitoring, like an EKG or a longer cardiac monitor, to get a better idea as to what the rhythm is that's going on.
Thank you very much for explaining that. And I figure we can wrap up a little bit with some of our audience questions related to a few of our earlier points. So this one comes from Laurel Wolf. What kinds of follow-up care would be helpful for gestational hypertension, preeclampsia, or postpartum preeclampsia? I'll give this to the entire panel for you guys to jump in.
One of the things that we like to say is that pregnancy is often your very first stress test, right? So many people can develop conditions during pregnancy, such as high blood pressure, um, uh, high blood sugars, which are often an early warning sign that there may be problems down the line. If you have a history of preeclampsia or gestational hypertension, meaning your pressure is elevated in pregnancy, it is really advised that you follow up with a cardiologist after you deliver to monitor your blood pressure, put you on appropriate medications to make sure we keep the pressure down. Some people's blood pressure after they deliver gets better and stays within the normal range for many years, but we often find that later in life, the blood pressure or the high sugar levels do come back. Some people during pregnancy also can develop heart failure. There is a special, what we call a peripartum cardiomyopathy or heart failure of pregnancy, in which case we'd have you see one of our, advanced heart failure specialists for monitoring. So oftentimes conditions during pregnancy are often sort of your first indicator that later on in life you may have other cardiovascular issues, and it's a really, really good idea to follow up regularly afterwards, even if things seem to get better in the immediate aftermath. It's still a really good idea to follow up intermittently with your cardiologist and at least have your primary care continue to monitor.
Okay. Thank you very much. Very good information. I'm 6 months postpartum, so okay, all that information is still top of mind for me, paying attention to my body as time goes on. Thank you, Dr. Ketlogetswe. We have one last question. This is another one from OK. Going back to a point that you made, Dr. Farrakhan, about those minimally invasive treatments, they're asking, do you need to stay overnight for cardiac cath procedures?
So it's a really good question. I get a lot of questions like that from my patients. How long do they want to stay? How long do they have to stay? Um, and it depends on what we're doing. There are certain procedures, let's say it's an outpatient case, and I'm just doing a procedure to check the pressures in their heart, for example, like I did one this morning. If the pressures are normal and the patient is stable, then they can go home the same day. Even if I do a stent, if it's an outpatient stenting case, if it was not a complex procedure, things went smoothly, the patient is feeling well, they can be discharged the same day. If it is more of an inpatient procedure, then of course we kind of take into account what else is going on to bring them to the hospital, to really determine the length of their hospital stay. Even for valve procedures nowadays, with the expertise we have, the skill level we have of all our structural cardiologists, the length of stay for even a big valve procedure is getting shorter and shorter. So it really just depends on patient characteristics and how stable they are in terms of symptoms and their blood pressure, heart rate, etc., that determines if they can leave the same day or not.
All right, very good question. And thank you, Dr. Farrakhan, for answering that. We have come to a close, so I want to thank all of our viewers for tuning in, sharing your questions and comments with us. We really appreciate it. Huge thanks to our amazing panel, Dr. Ketlogetswe, Dr. Farrakhan, Dr. Gupta, and Kerry Lynch, for sharing your expertise. We really appreciate it. It's a very important conversation. If you found this video helpful, please share it with your friends, tag your loved ones in the comments so they can get this information, so that they can benefit from it. For any more information about our providers here, if you'd like to schedule an appointment with us, please visit the link in the comment section, or you can call us at 410-248-8465. We're going to put all of that information in the comments as well. We want to remind you to stay strong, stay informed, and most importantly, stay heart smart. Take care of your heart, and we'll see you next time. Have a good one.